Hello, my name is Ajalitha Singhani. Together with Doctors Carver and James and one of our dietitians, Emily Weatherup, we have created a presentation that will give you an overview of diabetes care in pregnancy. You will see red boxes throughout that were taken from ACOG practice bulletins. Thank you for partnering with us in the care of patients with diabetes. In general, pregnancy is a state of insulin resistance. Maternal hyperglycemia leads to the production of reactive oxygen species that cause placental vasculopathy and cell death in the fetus that can lead to anomalies and growth restriction. Conversely, the elevated levels of human growth hormone in the placenta lead to increased insulin resistance and elevated glucose levels in the mother and the fetus, as well as driving macrosomia. Increased insulin in the mother then leads to a state of starvation in the mother that can lead to lipolysis, ketoacidosis, and DKA. Patients with diabetes in pregnancy are at an increased risk of a multitude of comorbid conditions, including hypertensive disorders of pregnancy, nephropathy, retinopathy, diabetic ketoacidosis, and infection. Neonatal risks are high too, with the most common being macrosomia, which is a fetus greater than the 90th percentile for gestational age, and hypoglycemia. Other risks include the risk of preterm birth, which is mostly due to indicated preterm birth, necrotizing enterocolitis, sepsis, respiratory distress syndrome, hypocalcemia, hyperbilirubinemia, cardiomyopathy, long-term cognitive delay, and diabetes later in life, as well as stillbirth. Although insulin needs generally decrease in the first trimester, placental hormones increase in the second and third trimester, and they result in insulin resistance. The effect disappears with the removal of the placenta during delivery, and patients have less insulin needs than prior to pregnancy. Gestational diabetes is a pregnancy-associated diagnosis. All patients are screened with a 1-hour glucose challenge test that is not fasting. Patients with a glucose greater than or equal to 135 then undergo a 3-hour glucose tolerance test, which is fasting. The 1-hour GCT may be performed in the first trimester for high-risk patients, such as those who are obese or have a history of gestational diabetes in a prior pregnancy. Patients who scored 195 or greater on a 1-hour test are considered to have gestational diabetes without the need to complete a 3-hour test. Some patients, such as those who have had bariatric surgery, are unable to complete the testing and can instead have their glucoses tested for a week at home. The levels for an abnormal 3-hour glucose tolerance test are shown here. The dietary recommendations are demonstrated here. In general, because pregnancy is a state of starvation, small regular meals are recommended. Exercise after meals improves glucose control because exercise uses recently acquired glucose molecules to burn as energy. Patients with GDM monitor their glucose in the morning and 2 hours after the 3 major meals. Patients with pregestational diabetes monitor their glucose in the morning before every meal and 2 hours after every meal. Goal glucoses are as follows: 95 for fasting, not on medications, and 90 with medications, 100 prior to meals, and 122 hours after meals. When at least 20% of glucose values are abnormal, treatment is recommended. Insulin is considered the first-line treatment in patients needing treatment, but metformin is an acceptable alternative in select patients, such as those who decline insulin, cannot afford insulin, or cannot administer insulin safely. Insulin is preferred over oral hypoglycemic agents because of the decreased risk of respiratory distress syndrome, hypoglycemia, macrosomia, and birth injury. Metformin decreases intestinal absorption of glucose and improves insulin sensitivity. Because of its safety demonstrated in pregnancy with metformin, metformin is often added to insulin to improve sensitivity in both type 1 and type 2 diabetics. Insulin amounts are calculated based on the expected insulin needs, but we start at 50% of the recommended dose to avoid hypoglycemia. As insulin needs increase in pregnancy, the dose calculations increase in pregnancy. Patients will be on a variety of insulins that last anywhere from 1 hour to the entire day. Lispro or Aspart is the most commonly used short-acting insulin. NPH is usually used in GDMA2 patients. Detamir or Glargine are used in pregestational diabetics. Glargine has the advantage of low levels of fluctuation throughout the day. In general, gestational diabetics act like type 2 diabetics light. They have an acute insulin resistance and have endogenous insulin that needs to be supplemented. They can better tolerate insulin spikes or missing meals because they can decrease the amount of endogenous insulin. Type 1 diabetics, in contrast, produce no insulin. They need insulin even when they are not eating and need D5 supplementation with that. They cannot receive a dose of insulin without a meal. Often, type 1 diabetics are on pumps. Pumps administer continuous insulin along with a bolus for meals and corrections. Patients enter the amount of carbohydrates consumed, and the pump delivers the associated insulin and correction based on the glucose at the time of carbohydrate consumption. Sites need to be changed more often in pregnancy, at least every 3 days. Some pumps have a feature called Control IQ, where the pump automatically changes the basal rate based on real-time glucose data. These pumps are not ideal in pregnancy because the glucose level is higher than the targets for pregnancy. Often, type 1 diabetics have CGMs or continuous glucose monitors. Most patients with a pump have continuous glucose monitors, but it is not always the case. Sometimes these monitors can be inaccurate. Some brands of CGM allow for calibration. If this is unsuccessful, a site change may work. If the patient is admitted to the hospital with a CGM, they should have an hourly glucose check for the first 2 hours to ensure accuracy. Patients with A2-GDM are most commonly started on a regimen of short-acting and medium-acting insulin. Both are given twice and usually mixed together. Lispro/Aspart peaks at an hour and usually covers breakfast and dinner when administered. NPH peaks at 6 to 8 hours and covers lunch and overnight. Because of the length of NPH, patients may wake up hyperglycemic and need their NPH moved to nighttime instead of dinner time. Type 2 diabetics are often on a regimen of short-acting and long-acting. The short-acting is administered with every meal. Although Detamir theoretically works for the entire day, it ends at about 18 to 20 hours, and patients in pregnancy generally need twice daily dosing. Patients diagnosed with diabetes mellitus requiring treatment require growth ultrasounds and twice weekly antenatal testing. Macrosomia is a known complication of diabetes, as explained previously. Neonates born to diabetic mothers tend to have shoulder and truncal obesity, and this increases their rates of cesarean delivery and shoulder dystocia even at normal weights. A primary cesarean delivery is offered for suspected macrosomia with an EFW of greater than 4,500 grams. Early induction of labor for suspected macrosomia does not modify the risk of complications. All diabetic patients on medications undergo twice weekly antenatal testing at 32 weeks because those patients have an increased risk of fetal death. Chronic hyperglycemia leads to fetal hyperinsulinemia, which in turn causes aberrations on oxygenation, lactic acidosis, and ultimately fetal death. Additionally, fetal hyperglycemia leads to fetal polyuria and resultant polyhydramnios. Delivery timing depends on the type of delivery. Patients with well-controlled GDMA1 have pregnancy complication rates comparable to the general population. Patients with poorly controlled diabetes have a high risk of stillbirth, thus recommending delivery in the preterm period. Of note, neonates born to diabetic mothers have delayed lung maturity, and this complication has to be weighed against the risk of stillbirth. Intrapartum diabetes care needs to be particularly stringent to decrease the risk of neonatal hypoglycemia. Maternal glucose crosses the placenta, but insulin does not. As a result, the fetus produces insulin to treat the glucose. After delivery, the cessation of glucose precedes the cessation of insulin, resulting in hypoglycemia. Insulin infusions are used in a multitude of situations. For instance, steroid administration for fetal lung maturity causes a temporary state of hyperglycemia that lasts 24 hours to 5 days, with a peak at approximately 48 hours. An insulin infusion can be ideal in this situation to achieve optimal glucose control, given that patients receiving steroids are usually expecting delivery. If patients have an unknown insulin need, total insulin calculation can be calculated by the insulin infusion. During labor and delivery, at the time of a cesarean, an insulin infusion is ideal for optimal glucose control. With gestational diabetes, this is started if the glucose is over 110. With an insulin infusion, glucose should be checked hourly unless being tracked by a continuous glucose monitor. This works as a basal insulin, and additional boluses are needed for meals. Patients with type 1 DM need fluids with D5 in addition to insulin when not eating. These orders can be found by typing insulin in the order sets. There are a variety of insulin order sets used for a variety of reasons. The END correction scale is meant for a pre-meal correction or Q4-hour correction in type 2 and gestational diabetics that are not eating. The subcutaneous insulin therapy has a variety of insulins that are used for all non-drip insulins. The 2-hour insulin infusions are divided by the type of diabetes and not when they are used. They reflect the different sensitivities to insulin expected based on the etiology of the disorder. The insulin set has an insulin infusion section that describes the initial rate of infusion and methods for titration. So, for instance, if the initial glucose is 120, the patient starts at 1 unit. If at the next check the glucose is still at 120, the rate is increased to 1.5, and so forth. This order set also has additional insulin in the form of a carb ratio for meals, as the drip only functions as basal insulin. Patients with GDM have a fasting and 2-hour postprandial check, and most patients do not require long-term insulin. At 6 weeks, they should undergo a 2-hour glucose tolerance test to determine if they have type 2 diabetes. After delivery, type 1 and type 2 diabetics under adequate control return to their pre-pregnancy type of insulin or medications. Most or all medications are not studied in breastfeeding, but sulfonylureas and metformin are safe in breastfeeding. Patients on insulin should restart an insulin dose that is approximately 50 to 75% of their pre-pregnancy dose if they were well controlled, because postpartum patients experience a honeymoon period of insulin hypersensitivity prior to returning to their baseline. Patients who were poorly controlled prior to pregnancy, either demonstrated by an unclear regimen or a high hemoglobin A1C at the start of pregnancy, should be kept on an insulin drip after delivery for 12 to 24 hours and subsequently started on an appropriate regimen based on determined insulin needs. These medications should be preferably started at nighttime. Hypoglycemia is common in pregnancy. In type 1 diabetics, this is most common in the first trimester when nausea precludes eating. In this case, patients may administer an appropriate dose of insulin prior to a meal, but be unable to complete the meal, leading to hypoglycemia. In general, this is more difficult to return from because the glucagon response is poor. In addition, every episode of hypoglycemia leads to a worsened response, leading to a vicious cycle. Patients who are not eating should receive 50% IV dextrose at 25 milliliters. Patients who are eating can try juice or glucose tablets as a first line. In cases of insulin overdose, glucagon may be administered as well. Correction scales are a useful tool for quick glucose corrections. In general, these are meant to be a pre-meal correction so that the mealtime correction of glucose lands the patient in a normal range. For example, if a patient starts a meal with a glucose of 140, a normal amount of insulin for the meal would result in a high glucose, so additional units in the form of a correction are given. Correction scales are not meant to be an hourly correction because each dose of insulin lasts longer than an hour, and correction this way can lead to stacking on each other and inadvertent hypoglycemia as a result. If patients are persistently high despite treatment, an insulin drip should be employed. Sliding scales can be used no more often than every 4 hours for treatment. Patients who are pregnant are at an increased risk of diabetic ketoacidosis due to lower thresholds. Patients can develop DKA even at a glucose of 300 or lower and can be diagnosed with a low bicarbonate and ketones in the urine. IV fluids are the first-line treatment, and patients urgently need large bore IVs placed. Patients then receive a loading dose of insulin followed by a maintenance dose. When their glucose drops, they may start receiving D5. Patients with DKA need fluids and insulin in addition to potassium and bicarbonate if indicated. Serial labs can help determine resolution. In addition to treating DKA, determining the cause is important. Infections, noncompliance with medications, and steroid administration can all precipitate DKA. Thank you for listening to this presentation. Supplemental information is provided.